to introduce our next two speakers within this COVID, patient safety, and the future session, who will both focus on key insights and lessons learned for enhanced patient safety. I am now pleased to introduce another good friend and ally of AAKP's, Dr. Alan Kliger. Dr. Kliger is a clinical professor of medicine at Yale University School of Medicine. He is also Vice President and Chief Quality Officer for Yale New Haven Health System. Outside of his academic roles, Dr. Kliger is Chair of Nephrologists Transforming Dialysis Safety and co-chair of the COVID-19 response team, both for the American Society of Nephrology. Dr. Kliger, I turn it over to you.
Hello, everybody. I'm Alan Kliger, New Haven, Connecticut, and I want to thank the AAKP and George Washington for allowing me to have this time with you. We're going to have a chance to talk about COVID and how it affects people with kidney disease and dialysis and transplant patients. Now, you'll all remember that when this first came along, when the pandemic started, it was brand new disease. We had absolutely no idea how it would affect the population and how it would affect people with kidney disease and those people on dialysis or transplant. So what I want to do today is share with you some of the clinical studies that have been done that showed us how dialysis and transplant patients fare with this illness and what we've learned about what we must do. I have no conflicts of interest to declare. This was a joke that was circulating 2.5 years ago at the very start of the pandemic, at a time that everything shut down. And I know you'll remember that because it was a really frightening time, particularly for vulnerable people like those with chronic kidney disease or those on dialysis or with a kidney transplant. So let me run through some of the studies, first dealing with people with chronic kidney disease. In a New York City hospital that studied about 4,300 patients coming into the hospital with COVID-19, you'll see here that they saw 4,000 people with normal kidney function and 280 patients with kidney disease. They then looked at how many of those patients survived and how many did not survive the illness. The mortality was 20% for people with normal kidney function, but 30% for patients with chronic kidney disease, clearly showing that kidney disease is a risk factor for more death and perhaps for more complications than others are. Dialysis patients in particular are particularly prone to acquire COVID-19 for several reasons. Number one, because dialysis patients have a higher numbers with diabetes, obesity, hypertension, cardiovascular disease, those things that make us all more prone to complications from COVID. Patients also have questions about their immune status, and I'll be talking more about that a bit later in this talk. And in particular, patients who are in center for dialysis cannot socially distance. We're all frequently exposed to each other, staff and patients, when we have a forced time indoors together. And so this was another high risk factor for acquiring COVID-19. And finally, I'll talk a bit about transportation because getting to and from the dialysis unit also made patients more prone to develop infections. Now, this has to do with how we get to and from dialysis. This was a study that was done and published by the National Kidney Foundation that showed a quarter of us get to the dialysis unit by private car, all by ourselves, but 3/4 of us either come by public transportation or come in vans or ambulance or ambulettes where there have to be drivers and other health people. And so it turns out early in the pandemic, being inside of a bus or a car or a train exposed to other people by requirement was a risk factor for acquiring the infection. A very important study was done in London that gave us good information on dialysis patients and COVID. In this London unit, 1,530 dialysis patients were examined. Of that group, 300 developed COVID-19. That's 20% of the population. 1 out of every 5 of those dialysis patients got COVID. The infections were more likely among people who came into center than if they were home dialysis patients. So being at home was clearly protective, presumably because those patients didn't have exposure to so many other patients in center. Also in this London unit, it was noted that clustering in specific dialysis units and shifts was present. So infections happened in clusters, presumably because of the contact that patients had with each other and that they had with nursing staff who also had high rates of illness. Most importantly, once this unit started using universal masks, gloves, and protective equipment, the number of infections dramatically fell. In fact, in the United States, after we started using universal gloves, masks, and protective gear, catching this infection, catching COVID-19 in dialysis units virtually went to zero. Looking at the European population early in this pandemic, patients who were dialysis patients who contracted COVID had a high incidence of complication and even death. If you look at the mortality of patients who were hospitalized with COVID, 1 out of 3 did not survive. And among patients who were admitted to the intensive care unit, over half of them did not survive. Let me just review early on what we learned about COVID. First, chronic kidney disease and end-stage kidney disease, that is dialysis or transplant patients, are at high risk of complications from COVID-19. In the pre-vaccination era, up to 25% of infected dialysis patients did not survive the illness. Now, today, that figure is very different. Today, mortality rates are less than 5%. It's not 25% anymore. Still, that 5% is higher among dialysis patients than the mortality in the general population. Masks, gloves, gowns, eye protection reduce dialysis unit transmission to nearly zero. Now let's turn to talk about kidney transplant patients. Here again, early, it was found in the New York experience, 36 consecutive transplant patients who turned positive for COVID-19 were examined. 3/4 of them required hospitalization. 1/3 of them required mechanical ventilation, meaning being on a ventilator. 17% had kidney failure and required dialysis, and 1/3 of them died. A really frightening picture early in this pandemic. By a year or so later, when a large group of transplant patients were examined out of Germany, it was found that the in-hospital mortality had dropped down to about 9%, much lower than the early experience. Those patients who were transplant patients had a reduced immunosuppression and increased rejection rate, although the all-cause mortality remained unchanged. So if the early on experience for dialysis and transplant patients showed that it was a real risk, what did that do to the dialysis and transplant population? So I'm going to show the next 2 slides that show pretty dramatically the effect of this disease on dialysis and on transplant patients. Here you see the dialysis population before COVID-19, from the year 2000 to the year 2019. This shows the cases per million population. And as you see, every year there was clearly evidence of a rise in the number of patients and in the prevalence of dialysis up through 2019. On this next slide, you see what happened to those populations after COVID. Here, the black line represents the dialysis population, and below that, the blue line represents the transplant population. And as you see, both were growing. The red line shows when the pandemic began. And you see pretty dramatically that the dialysis population fell for the first time in decades as a result after the COVID pandemic began. Likewise, not quite as dramatically, but likewise, you can see at the bottom line that the transplant population also did not continue its same rise, but leveled off rather than rising. Looking at these data, it's really clear that COVID-19 has had a significant effect, particularly on the dialysis population. All right, let's now move to talk about the vaccines. I want to talk about the safety of the vaccines, how well dialysis and transplant patients respond to getting vaccines. Do they develop immunity? And then if they do develop immunity, do the antibodies remain in place over time? So first, COVID vaccines clearly are safe for dialysis and transplant patients. The data that I won't show here shows that the safety of these is very high and very good. This was a very important study, and don't worry about looking at all these numbers because I'm going to be showing you slides to demonstrate this. But this was a very important study looking at how well people respond to getting vaccinated. It was a study that was published in the journal called Transplantation, and it compared how well patients with kidney transplants develop good antibody responses to vaccines compared to dialysis patients, compared to people with kidney disease before they're on dialysis or transplant, and then finally compared to people with no kidney disease at all. This is a slide showing dialysis, transplants, and chronic kidney disease patients to vaccination. Do they respond? In each of these bars, the gray shows responses after the first vaccination, and the darker color shows responders after the second vaccination. The white in these bars show people who don't respond. And as you can see, starting on the left bar, people with no kidney disease have an excellent response, up to nearly 100% develop antibodies after vaccination. On the second bar, patients with chronic kidney disease, not on dialysis or transplant, have a very similar response. By the second vaccination, nearly 100% develop antibodies. The third bar shows dialysis patients. And this was a bit of a surprise, at least to me, because here what you see is that while only 85% or so of dialysis patients responded with antibodies after the first vaccination, virtually 100% of dialysis patients do develop antibodies after the second vaccination. At the last bar on the right, you see a very different response in kidney transplant recipients, where only a little over 50% develop any antibodies after one or two vaccinations, and where half of transplant patients have no antibodies at all. This is a slide that shows those same groups, but those who have neutralizing antibodies. That is the kind of antibodies that fight the virus infection. And here you can see people on the left who have no kidney disease, called controls, are compared in how many antibodies they have compared to people with chronic kidney disease and dialysis patients, and then compared to kidney transplant patients on the right. So here what you see is that the antibody responsiveness, how well people develop protective antibodies, if you're a dialysis patient or if you have chronic kidney disease, the response is pretty good. It's pretty much the same as people with no kidney disease on the left. But kidney transplant patients on the right have a much, much lower response of these antibodies. And then number three, there are, besides antibodies, other parts of the immune system that protect us against infection. This is the ability of certain lymphocytes called T cells to respond to vaccination. Here again, the gray shows a high T cell responsiveness showing good protection, or in the white, a low T cell responsiveness showing no protection from immunization. And what you see is that people on the left-hand bar, people with no kidney disease, have pretty good T cell responsiveness of about 85%. Patients with chronic kidney disease and those on dialysis have a modestly lower protective T cell response. But those on the right, people with kidney transplant, have a very low T cell responsiveness. So transplant patients have far less protection from vaccines than do normal people or people with chronic kidney disease or those on dialysis. Lastly, I want to show about antibodies, whether they stay or whether they disappear. This slide shows what percent decrease there are in antibodies after vaccination in people on dialysis compared to the middle, which is people who are normal people with no kidney disease. At 3 months, you see that all that control people as well as dialysis people have about a 70 to 80% decrease in the number of antibodies. And at 6 months on the right-hand side, normal people and dialysis people have about a 90% decline in antibodies. So dialysis patients lose the protectiveness with time, just the way people with no kidney disease do. Next, I want to talk about something I know you've all seen, and we're seeing like crazy now, which is that fully vaccinated and boosted people are still getting COVID-19. And so I've wondered, and others have wondered, why would that be? If we have all this good protection, why is that happening? Well, first, I just showed you how vaccination causes good protection, both with antibodies and with T cells, in people with normal people and people on dialysis. The second is that breakthrough infections of fully vaccinated people are very common. We're seeing them every day. If we look carefully at those breakthrough infections, it turns out the virus is not as strong as it was if you don't have immunization. The viruses don't replicate, or they don't make new viruses 4 to 6 times as much if you've been immunized. And there's also that virus shedding after breakthrough infection is shorter in duration. So it's very clear that immunizations affect the virus itself, but don't stop infection in the upper airway. And so one of the possible reasons for that is that while fully vaccinated people have excellent protection in their bodies, they may have less protection at the site of entry. Where does the virus enter us? It usually enters in the nose, in the mouth, in the upper airway. So on this next slide, some people have wondered whether mucosal immunity, immunity in the mouth, in the nose, on the tongue, in places where the virus enters, may be different than immunity in the rest of the body. The mucous lining of the nose and the throat is the entry site for viruses. The immune system of the mucosa is different than the immune system circulating in the blood and the rest of the body, because mucus contains a different type of antibody called IgA, and different types of T cells, are in the mucus and in the lining cells of the nose and the mouth. The vaccines we all get give us very good systemic immunity in our bodies, but do not give us mucosal immunity. So this slide shows some of the work, very exciting work, that's now going on with the understanding that total body immunity that we get with the injections is different than immunity in the mouth and in the nose, and showing that maybe we need 2 types of protection. One is that intramuscular immunization on the right-hand side that protects our tissues and in our bloodstreams. And second, science is working on a nasal spray, something that could be a vaccine that would allow the cells of the mouth and the nose to develop the right IgG antibodies to protect there. So this is something perhaps that'll be really useful in the future and may be able to stop infection, even these breakthrough infections. Finally, I want to talk a little bit about the medicines that are available to fight COVID should you develop a COVID infection. There are two types of treatment. One is to give antibody infusions to boost your body's immune system. And the second type of treatment are antiviral medicines, sort of like antibiotic medicines, that can kill the virus itself and prevent its spread in the body. So what do we know about that? We know, as we talked about before, that transplant patients usually have low antibody levels after vaccination. So treatment with monoclonal antibodies, these infusions of monoclonal antibodies, may be very helpful. Dialysis patients usually have loads of antibodies, so these monoclonal antibody treatments may not be as helpful. There have been developed several antiviral diseases that are potentially helpful, but the current antivirals may have many incompatibilities with other drugs that we're all taking and are not currently recommended when the kidney function is impaired. The two most common antiviral drugs right now are remdesivir and Paxlovid. Remdesivir has been used in people with mild kidney impairment, but not people at stage 4 or 5 chronic kidney disease. And Paxlovid is not recommended in patients with severe kidney disease until more data are available. Lastly, long COVID. You've heard about this, that people develop symptoms and keep those symptoms long after the infection is gone. And they've been described with neurologic symptoms and others that are shown on this slide. That's the general population. Well, we now have information about the dialysis population and long COVID. This study showed a group of patients who had symptoms for 6 months after their infection was gone. In this study, 18% of dialysis patients who had had COVID infections experienced long COVID. So 1 out of 5 having these symptoms 6 months or more after infection is gone. The commonest symptoms that people have with this are muscle loss or weight loss, extreme fatigue, or symptoms of cough or upper respiratory illness. We're learning more about these patients, why they're having that, and so far we don't have any clear answers about what to do to help with that. In this last slide, I'll just talk about the current challenges that our dialysis industry has with the COVID. The first, of course, is vaccine hesitancy. There are still some patients and some staff who have chosen not to get vaccinated. And those people are much more prone to develop infection, and if they get infected, complications. Our dialysis staff are stressed. Depression and burnout have been reported at high rates. And the Great Resignation affects our staff just as it has others across the country, where dialysis nurses and technicians are short-staffed virtually everywhere in the country. Finally, the supply chain is affected. That dialysate, the fluids that are used to do hemodialysis, are in lower supply, and some facilities have had to decrease the rate that dialysis solutions are used during dialysis to take care of that. So in summary, first, dialysis patients remain at particular risk for COVID-19, particularly if they don't receive vaccination and boosters. Second, home dialysis appears advantageous, probably because you're not being exposed to others with disease. Transplant patients often do not develop immunity after vaccination. Dialysis patients and patients with kidney disease before they start dialysis have an excellent immune response following vaccination. Treatment for COVID infection is tricky for dialysis and transplant patients. Monoclonal antibodies may be helpful in some. Antiviral medicines are still being studied. long COVID. We don't know much about it yet, and we'll have to watch and see. Thanks for listening. Thanks very much again to AAKP and to GW for allowing me to give this talk.
Thank you, Dr. Kliger, for a great presentation. Thank you to our audience for joining us.